Okay, so talking today about substance dependence treatment, and first talking about the treatment of alcohol dependence. So one way to treat alcohol dependence is basically by detoxification. So getting all of the alcohol out of the person's system and then seeing that person through the withdrawal symptoms. This can take place at home, under outpatient care, or in the hospital. Some of the withdrawal symptoms can be pretty nasty. So things like seizures can happen, the delirium tremens or the DTs. This is, shaking. They're accompanied by disorientation and visual hallucinations. Additionally, you might also prescribe for the person a drug that's called antabuse, which is based on counter conditioning. So this is classical conditioning in action, where the person takes antabuse and then if they have a drink, it causes severe nausea and vomiting. The problem is that if the individual does not take antabuse, then they can drink and not have the severe nausea and vomiting. The idea is that you want the client to relearn essentially an association between alcohol and an unpleasant experience like nausea. You want them to become counter-conditioned. Multimodal treatments, this is basically using multiple different forms to reach the patient. So you might use support groups like Alcoholics Anonymous. Social support provides the remainder of the help that's available. From AA, they believe that once you're an alcoholic, you're always an alcoholic. You can never go back to normal drinking. There are regular meetings. You have a sponsor, someone who has already been through the process, who can help you through tough times, and there are 12 steps to recovery. Those who stay with it do get better, and those who are highly motivated, most confident, and most active in their coping are likely to continue to benefit. Outpatient treatments exist as well, so you might have a residential treatment, day hospitals. There appears to be no difference in individuals who go inpatient or outpatient, and then there are other brief treatments such as motivational interviewing, which increases the motivation of the person to change. It basically looks at how ready the person is to change and then tries to align with the client and kind of capitalize on the individual motivation to change. Relapse prevention, very important, since most alcoholics who stop drinking eventually relapse. Oftentimes, relapse begins with high-risk situations. So this can be, being around other people who are using. Abstinence violation effect causes slips to turn into relapse. Okay, so looking at other understandings of where substance problems come from, looking at a psychodynamic approach. This approach states that drugs address anxiety that individuals have about some kind of new role. So the individual is in conflict with some kind of new role, such as moving into adolescence, for example, and drugs help you to be able to deal with that conflict. To acquire self-care as the treatment here, psychodynamic theorists believe that you need to bring up the painful emotions that drugs suppress. They give suggestions to deal with the emotions, and the goal is to build up the patient's intrapsychic strength and improve their relationships with others. Psychodynamic perspective not used often in treating substances because their techniques are not empirically validated. Looking at a behavioral perspective states that there are rewards to using drugs. You use drugs to achieve some kind of pleasant state that is produced by release of neurotransmitters, particularly dopamine. So dopamine is involved in learning and reward. So then you need to unlearn this. You need to learn to not abuse drugs. So behavioral approaches use a focus on aversive conditioning only. So that's like using antabuse, right? You want the person to, instead of associating drug use with pleasant feelings, you want this person to associate drug use with unpleasant feelings. The problem is, though, that this aversive conditioning does not address the underlying problems that might lead a person to abuse substances in the first place. Okay, so a family systems perspective, this focuses on all of the people who are involved in maintaining drug use. So you might adopt couples therapy, which is used often in treatment of alcohol dependence, and it may be very effective for reducing relationship problems. For example, men who engage in domestic violence oftentimes also meet criteria for alcohol dependence. So behavioral couple therapy reduces violence and also tries to reduce drinking. Family therapy, we're working with all of the systems involved here. So school, work, church, instead of providing support to just one of these areas, we use the family as a support. We treat the entire family in the process. Most drug-dependent individuals live with their parents or have daily contact with parents, and this particular approach seems very promising, particularly for teenagers, adolescents who abuse drugs. With a cognitive perspective, we're looking at how you think about drugs. So, for example, many individuals might have very positive expectations or expect positive things to happen as a result of using drugs. So they expect to experience pleasure, enhance sexual performance, and this can lead to excessive consumption of the substance. So then your goal is to work through cognitive behavioral therapy to control cognitive responses to relapsing. And we're trying to take these small relapses or these slips from becoming a full-blown relapse. So we want to identify the errors in thinking here. So for example, someone might think, oh, if I have a drink, I might as well get drunk. So your job then is to work with the client on attacking that kind of thinking. You also want to work with the client on identifying potential risk factors. So in the individual, these can be things like negative emotional states, anger, depression, poor coping skills that can eventually lead to a full-blown relapse. Within the environment, you want to look at social support. Do they have it? Do they not? Is there interpersonal conflict going on, or perhaps pressure from outsiders to use the substance? And then you want to look at physiological risk factors as well, such as withdrawal cravings. And these are particularly dangerous when they're combined with individual risk factors, like those negative emotional states, and environmental risk factors, like hanging out with other users. So you want to be able to target those particular risk factors and help your client develop coping skills to deal with those risk factors so that it doesn't lead to a full-blown relapse. Okay, neuroscience perspective, looking at genetic studies, we see that there is an inherited predisposition for problems with alcohol. Looking at biochemical studies, endorphins. These are those feel-good chemicals that mimic morphine, and we find that there are nerve cells in the brain that have opiate receptors to which opiates attach themselves. Over time, with repeated opiate use, the body actually stops producing endorphins, and then individuals have to rely entirely on opiates to feel good and control pain instead of the body naturally producing these painkillers or these feel-good chemicals of endorphins. Looking at dopamine also, we find that dopamine production creates the drug's positive effects. So dopamine, most abused drugs stimulate dopamine-producing neurons. So dopamine is absolutely involved in this learning and reward process for addictive substances. Drug treatment for drug dependence, there are a number of particular things that you might look at here. We've already talked about antabuse, but another option can be methadone as a replacement treatment for heroin. So methadone is also addictive, but it does not produce the extreme euphoria of heroin, but it does satisfy the craving for heroin, and it also prevents the experience of those really unpleasant withdrawal symptoms. Methadone maintenance switches people from dependence on heroin to dependence on methadone. Some of these programs have been successful using methadone, but it doesn't prevent the user from becoming dependent on other drugs. So while the person is using methadone, they can still become dependent on other substances, and many users relapse when methadone is no longer provided. So they go back to using heroin when methadone is not available. Looking at a sociocultural perspective, we want to look at how things like poverty and other societal factors increase likelihood of drug use. So we see that drugs disproportionately harm African American and Latino communities. And looking at harm reduction, as a potential way to deal with drug problems. This might be the understanding that if people are going to use drugs, which people are going to use drugs, so let's try to reduce the amount of harm that these drugs cause to people, perhaps by having needle exchange programs where individuals who use drugs intravenously can come to a place, bring their used needles and get clean ones to prevent the spread of things like HIV.